All right. Well, thank you so much to Dr. Major and Dr. Steen for two really beautiful talks. I felt like those were super high tech. And, you guys are both leaders in your field and you consistently demonstrate just beautiful imaging. But I want to break this down and sort of talk a little bit about how this can be made very practical to basically everybody in clinical practice. So, Dr. Steen, I'm going to start with you. You talked a little bit about these beautiful cases of geographic atrophy progression analysis, and distance to the fovea. How often are you doing that, and what are you doing with that information?
The practicality is always the key. And in an academic center, it is the real focus of being as clinically practical as possible and as reasonable to do. Now, in a geographic atrophy case, I typically see those patients every 3 months, and I truly am watching for progression. Once you've made the diagnosis, the next step, just like in glaucoma, is number one, is this patient progressing? And if so, how quickly? From a referral standpoint, I'm trying to best understand at what point may this patient be a good quality candidate for potential therapy. And that's the important information that I'm sharing and continuing to communicate with the managing retinal surgeon or with the managing retinal physician. So the pieces to say, how quickly is this patient changing? How quickly may treatment be warranted in this patient's case? And sharing that in a meaningful way.
And so, Dr. Major, I know you also follow a lot of patients with geographic atrophy. How often when is your threshold to go and say, I'm going to communicate with my retina specialist to say, "Hey, is this somebody who I should be sending to you? What's that level? What are you looking for to make that referral?"
Yeah, I set that threshold pretty low. I mean, at the first onset of true geographic atrophy, I'm really referring to retina specialists to get a sense of whether this patient may be a potential candidate for complement inhibition therapy, because we only slow the progression of geographic atrophy. We know the earlier we start treatment, the more vision and the more retina we can save over time. So I set that threshold really low.
Yeah, and the other thing which I love is that you're following these patients over time. And so sometimes, a patient may be in Dr. Steen's clinic for like 4 years and then show up to, to my clinic for the first time. And understanding that change over time can be really, really valuable. So I can almost sort of imagine sort of a teleretinal communication where you're sending over the progression, the GA analysis, the distance to the fovea analysis, and that can help be very actionable for me on my end. So, the other thing is that when we're following a lot of patients with geographic atrophy and macular degeneration, these patients also have glaucoma. And we saw in the glaucoma session earlier a beautiful case of GCIPL thinning. Dr. Steen, you also had a case of that. Tell us a little bit about how do you look at that GCIPL in the setting of patients with macular degeneration?
So we do have to think about the context. So what exactly are we measuring? And what do we think we're measuring? And are those two pieces always identical? Understanding that segmentation differences can impact our interpretation. So when we're losing the outer retinal tissue, we have to think about what happens to the inner retinal tissue. And that collapse, that depression, that change certainly does have an impact on what is being measured as the ganglion cell interplexiform layer analysis versus potentially what's actually happening at the level of the ganglion cell interplexiform layer.
Perfect. Perfect. And Dr. Major, I'm going to switch gears here. Let's go talk a little bit about the inner retina. We spent a lot of time talking about the outer retina. When we think about the inner retina and you're showing all these incredible images, not everybody has OCT angiography. And next year in 2025, there's going to be a billing code for OCT angiography that may ultimately change how we sort of implement this, and it may provide some meaning for how we can ultimately use this in clinical practice. How often, when you're looking at a patient with diabetic retinopathy, do you sort of identify them perhaps to have maybe moderate diabetic retinopathy? You then send them for an OCTA and then find some discrepancy between your clinical exam and what you're seeing on your OCTA.
Yeah, that's really a quite frequent occurrence. And I think the real value of montage OCT angiography comes when you have a patient who's moderately severe to severe NPDR that you're grading clinically, and then you do OCT angiography, and there was some sort of subtle neovascularization that you missed on clinical examination. And it's really critical, right? If you're dealing with severe NPDR versus PDR, because PDR I'm always going to refer out. And typically those patients get like PRP or some sort of treatment. So I'm not embarrassed to say that is actually quite a frequent occurrence. OCT in general, and especially OCTA, is huge in terms of highlighting these subtle vascular abnormalities that we can't see clinically or subclinical retinopathy findings. So there's a lot of value there.
Yeah, and it's also a great opportunity to sort of minimize the amount of fluorescein angiography that we do. A lot of times I'm doing a lot of ultra wide field FA on these patients, and then I've been switching more and more to 12 by 12 OCTAs to help me look for these changes. And sort of obviously, the greater the amount of non-perfusion, the higher the risk of progression because ischemia is driving that VEGF production. So, and sort of, I wanted to actually sort of talk, you highlighted all these beautiful cases of inner retinal thinning and middle retinal layer thinning in these sort of like focal areas. So when you're looking at that, do you think it's reasonable to assume that those are areas that are going to be capillary dropout? And do you try to quantify that in your mind when you're thinking about the extent of non-perfusion?
Yeah, absolutely. I think you can assume that areas of like inner retinal layer thinning or disorganization are most likely going to be areas of non-perfusion on the superficial capillary plexus. But it's hard, if you're just taking a macular cube and you're scanning through that 6 millimeters to know what's going on like out in the arcades or beyond the arcades. And so I still think there's a whole lot of value in doing the OCT angiography like montage or the 12 by 12, like you said, to kind of really gauge how much non-perfusion is present.
Gotcha. And then in my talk, I sort of talked a little bit about how in the chronic stages of RVO versus RAO, we have this really thin inner retina, but it's hard to know the differentiating features. And that sort of alludes to the polling question. And I will say, probably, I imagine, Dr. Steen, Dr. Majcher, have you ever looked at a patient and wondered whether it was an RAO versus an RVO in the chronic stages?
Most certainly.
Absolutely.
Yeah, and there is implications medically there, and to just sort of go to that polling question that we had, the question was: are all of the following findings that can help differentiate a BR from a BRO except? These are sort of those horrible questions that kind of bring us sort of like these terrible memories from like when we were back in school and taking exams, but inner retinal thinning oftentimes cannot help you differentiate between a BRAO and a BRVO. So looking at sort of the development of collaterals, which is a unique feature to venous occlusion, can be very, very helpful. So when you guys are thinking about that, are you getting fundus photography, OCTA, OCT? What's your sort of strategy when you're looking at these patients?
Yeah, for me, I find a whole lot of value in the OCT angiography because it highlights those like collateral vessels or retinal telangiectasias, like you had mentioned, and you can isolate out things like that in the deep capillary plexus. So there's a lot of value in visualizing that.
I think where I start is typically, in certain cases, even finding these focal areas of thinning or focal areas of abnormality, even as an incidental finding or as an anomaly, like was brought up earlier on ganglion cell analysis, and then digging in further. But that differentiator of OCTA is something that really does help to understand so that we can best understand and help to manage the underlying disease, systemic disease process.
Yeah, that's a really great point, right? So if you're following these patients for glaucoma, they have considerable cardiovascular disease, hypertension, hyperlipidemia, diabetes. What you may actually be seeing on your GCIPL are rather these changes in the inner retina. I wanted to sort of highlight it. So a lot of healthcare providers, we sort of think about the retina, and when it's swollen, it's so incredibly obvious to detect change, to detect pathology. But I hope that through this conversation that we've had today, that you will start looking at retinas and say, is it too thick or is it too thin? And both of them have severe implications. In the outer retina, this can be geographic atrophy. In the inner retina, this can be signs of severe microvascular disease. I really want to thank Dr. Steen and Dr. Major for their beautiful talks.